Before we begin, I would like to gratefully and respectfully acknowledge the opportunity to have this event take place on the traditional and ancestral territory of the Coast Salish people, specifically the Kwantlen, Samiamu, Tsawwassen, Katzie, Coquitlam, Kakwa, and numerous Stolo First Nations. Acknowledging that we are on the traditional territories of the First Nations community is an expression of cultural humility and part of our desire and duty to support the provision of culturally safe care to our First Nations communities, Inuit, Métis, people in our Surrey-North Delta community. To begin our evening, we're pleased to welcome Dr. Timothy Foggin, Medical Director of our Cloverdale UPCC. He'll share a brief announcement. We'll also have Dr. Elliot Bogush, who is our neurology specialist lead for this project, who delivered a phenomenal session in September on managing neuropathies. Dr. Bogush will speak on our project goals and introduce our presenters for the evening, Dr. Dex Arnold and Erica. So now without further ado, can you please welcome to the stage Dr. Tim Foggin.
Thank you so much.
In September, I joined Fraser Health in a new capacity, and that's as medical director for the upcoming Cloverdale Urgent and Primary Care Centre. I have been working at the Newton site for the last 2 years, covering quite a few evenings a month, and really excited to be building a team and getting to know the team of community physicians around Cloverdale. And so we have a few slides, which is this, just to tell you a little bit about it. And here we go. Basically, there are two streams, and you may be familiar with other urgent and primary care sites. As the name indicates, it's urgent and it's primary care, a longitudinal component. The longitudinal one, I'll just say a word, there's limited capacity, but the focus is for patients with a little more complexity who would likely benefit, who currently do not have a primary care provider and would benefit from having a multidisciplinary team. That's the theme there. And then on the urgent care side, as the name urgent care suggests, it's not for emergent. So if you do come or have some colleagues coming to work, there is a triage process to ensure that emergent cases are redirected appropriately. And it's not for non-urgent care, in as much as we look at it at the 12 to 24-hour kind of situation where individuals need to be seen. I'll come back to that. There are a few themes, a few values, a few approaches that I think are important and very much wanting to understand. And we have this both at the top and the bottom of this list that want to know the community physicians surrounding each urgent and primary care site, what's important to you, how we can become a part of the medical community. And if I jump, not because the others are unimportant, I'll let you read them, but at the end, clear communication back to you that you may know your patient was seen and what was done, and that we have this form of continuity. And I will be around for questions to go in detail. I know we're all anticipating a good session on Vertigo, and so just taking a few minutes. The focus of the urgent care, the mandate really is to help keep our patients or joint patients, our joint community members out of the emergency room when it's not emergent. And colleagues in the ED do state that 2/3 of their visits are urgent or non-urgent, but not emergent. So that's the mandate there. As you can imagine, minor injuries, acute respiratory, a number of conditions. The classic, you know this, I don't have to repeat it, but it gives a sense of what kinds of cases. And what's special with Cloverdale, it's only the second of all the UPCCs in Fraser that will have radiology on site. It adds an extra layer, and that we're working on how that can become a service broader in the community as well, an additional resource. There are some basic labs, and again, as individuals have either interest to know how their patients could be served or are interested in joining our team, can go into more detail with you. And sometimes the easiest to know is, what's it like if I were potentially interested, because we are opening up and building teams for 12 hours a day, 3 physicians on site at any time. So that's a lot to fill up at first, but it's easy from your perspective. 4 hours, if you want 8 hours, if you want 12 hours, I don't recommend 12 hours, but basically, it's an easy process, looking on what's available in the calendar for the coming month. And that being said, we're seeking to make this not just a transactional come for here, come for that, but a sense of common approach to patient care. And that's because we all have experienced as family physicians in the community how a patient goes somewhere and don't know what was done. And as one new friend just told me, sometimes comes back with antibiotics for an allergy. Like, what's going on? We want a common approach to the care we give. So, when you're on, it's really nice having a team setting. If you've not done shift work, some people are nervous. What does that mean? What will be thrown at me? It's actually, it works well. The first shift, you're welcome to come spend a couple hours, feel it out, watch it, take a look. And so just wanted to let you know, the service is coming to your nearby in Surrey. I'm now further to the east. And if you're interested, if you're looking for something new, maybe you want a little bit more procedural, a few lacerations here and there, INDs, what have you. Sometimes it's a change of pace. We would certainly welcome you. I think we're at 4.5 minutes. I'll hand the mic to one of my other colleagues and would love to talk with anyone who's interested.
So I'm really pleased to see, again, a large turnout tonight. One thing that I wanted to start off talking about was actually why we're actually here tonight. This was incepted probably a year ago to try to figure out how can family physicians, neurologists, and maybe later on additional specialists connect better with one another on behalf of their patients, on behalf of each other, so that we can know a little bit better of what each other is thinking rather than presuming that we're mind readers. As my wife says, I'm telepathetic, not telepathic. So that's why we really appreciate what you guys are telling us out in the crowd, on the online questions and after the fact, so that we are all growing together. And I think tonight's session is really nice because we're even getting allied health coming into the picture, and as was just mentioning, really broadening the team not only for between family physicians and neurologists, but for the various therapists that are out there as well that can help bring agency and progression for our patients. So one of the things that we also wanted to emphasize this, and as I did with my previous talk, was about use of the RACE app in context of reaching out to physicians. Neurology is available to you. We're actually looking if these sessions potentially have an influence on that to make people feel comfortable that they can reach out to us and that we can see what is needed out there more and more with those contacts. And these initial sessions are looking at things that we were seeing at the AGM as initial interests about various things like polyneuropathy, vertigo as is being discussed today, movement disorders in another session, and cognitive issues in another session. But that's always going to be a moving target because maybe once we fill your cup with vertigo knowledge, then that leaves you hungry for another topic to have us all grow and learn together. So tonight we have 2 speakers that are joining us. One colleague trained in University of Calgary. He works alongside myself in terms of consults in the hospital, both at Peace Arch and Surrey Memorial, as well as in the community clinic out in coastal clinics. And he's going to be, it's really hard to introduce this guy that's hiding behind the pillar, but happy to have Dr. Dex Arnold joining us today to give a talk about a lovely titled talk of keeping yourself and your patients upright. And as well, we're very privileged to have Erica Zaia, a vestibular audiologist, joining us today. So this is that complementary element that I was talking about. So I will pass on the mic to Dr. Arnold.
So yeah, we're going to talk about vertigo. I wanted to work on instilling an approach today to the diagnosis of vertigo. How do you kind of assess your patients coming in and break things up in your mind to get to a diagnosis? You know, I'm very happy to have Erica with us. She's going to take us through some of the vestibular rehab and treatment aspects of managing some of these conditions at the end. We're also going to have a live demonstration with Dr. Bogush as our patient, I think. And so we'll go through sort of those classical and important exam maneuvers that are not often done, the Dix-Hallpike, the Apley maneuver, the Hintz exam, and all those things, so everyone can see those things live. My disclosures, I've done some speaking for companies. We're going to touch briefly on migraine management, so it's maybe a little bit relevant. I'm not particularly recommending any prescriptions today. Okay, so in terms of what I wanted to cover was, you know, first clarifying exactly what are we talking about: vertigo, dizziness, unsteadiness, those kinds of things. Then again, having a structured approach. A lot of what I'm talking about is based on a very kind of important paper that came out in the last 15 years called Titrate, you know, using timing and triggers as important historical pieces of information. You have limited time to take a history, and using those elements, the timing of the patient's symptoms and what causes them, to try and narrow your differential diagnosis, your localization, and come to a diagnosis and management. I wanted to talk a bit about, you know, the exam. So we're going to do a few things. We'll talk about the physical exam. I'm going to show you some videos of findings, and then we'll also do a demonstration. And then we're going to touch on some of these etiologies and a little bit about management for the common causes. So in terms of terminology, dizziness. What is dizziness? Well, it's a sensation of disturbed or impaired orientation without a distorted sense of motion. It's a sense of something being off, but it's not actually moving. It's different from vertigo, where you have a sensation of motion when no motion is actually present. Now, this could be external vertigo, meaning that the environment around you is moving, or internal vertigo, the sensation that your body's moving and the environment isn't. Diagnostically doesn't really make a difference. It's just the concept of things moving. And that is what vertigo is. There's a sense of motion. Dizziness is sort of a more nefarious thing of something being off a kilter, but it's more of a static disturbance. Pre-syncope, we've all seen that, right? That sense of being about to faint. Some patients that haven't fainted before, haven't experienced it, have a hard time describing it to us. But, you know, often there's associated symptoms, vision closing in. They use the term lightheaded. They want to try and sit down to, there's an instinctual thing of knowing that you're about to lose consciousness. Often there's a muffling of the hearing and sweaty and associated other symptoms with a typical vasovagal syncope. And then unsteadiness really refers more to postural instability, and that can be standing and walking, which is more common, but also in the seated position. And you can have a directional preference, a sense of falling towards the right or to the left. In the world of neurology, that can have localizing value, and then you can also have a sense of being just off, like in an ataxia syndrome, and you're unsteady on your feet, falling to both sides. Yeah, I think one of the challenges we all have is taking a history from a patient, trying to fit it into one of these boxes. I think the point of my slide here is just saying that we don't do a really good job of this as a profession, as it's hard, okay? A lot of the times, like the other thing is there's a lot of, there's like 80 people here, which is really amazing to come hear me talk. I don't think it's worth it, but there's like a lot of people here coming to talk about vertigo, and like most of the time, guys, it's like a pretty benign problem. It's not that it's like not important to deal with it, but we'll get to it. But like a lot of this is migraine. It's like not life-threatening stuff. It feels horrible for the patient. You can help them with it, but like people don't die of these problems. The chance of it being a stroke, like that's the referral we always get, vertigo, query, stroke, it's really low. In the emergency room, the hit rate, patients coming in with dizziness and vertigo is like 2%, 2 to 5% of finding something sinister. So A lot of patients here are going to have benign pathology that we can deal with. A lot of the patients that have a CT scan, it's going to be negative. And there's even like if you've been discharged with a normal CT, there's a study looking at like the readmission rate super high because the patient's still dizzy because their cause of dizziness wasn't dealt with. They come back to the hospital and then it's like, oh, I must have had a stroke. They get admitted for an MRI and the MRI is normal. So we see that all the time. Oh yeah, and then the other thing is just CT scans, like plain CT heads, are also kind of like useless. So if you think that in this context, like you think the patient has, something really bad, if you stop at a plain CT head, like you'll find stuff. Like someone has a big meningioma causing mass effect. They've had a hemorrhage. They've had big pathology. You'll find it on a CT head a lot of the time. But if you are that concerned about a central cause of vertigo or something more complicated going on, you're probably going to have to go further than that. Okay, so. This structured approach I mentioned, the advantages here is it's pretty easy when we get down to it, okay? And it helps you kind of guide like what investigations you actually need. And it, in practice and also in the initial study, like it really does help you come to a diagnosis sooner. How can you kind of, look at these patients? Well, you can triage them. So I was mentioning, if you look at all the folks coming into the emergency room with dizziness and vertigo, 5% or less have a sinister cause. It's a lot of patients that have benign pathology. There are scoring systems that I've taken a couple from the literature that can help you risk stratify patients. How likely is this person having an ischemic event? And then we're going to go through some, important questions here to classify the vestibular syndrome, mainly the timing and the triggers involved here. And then we'll talk about the targeted bedside examination to confirm our diagnosis. A lot of this stuff you can diagnose in your office in a few minutes with a physical exam. Okay? The CT head that you've waited for will not tell you anything, and the patient will still be dizzy, and they'll just come back. So one of the more predictive, things in terms of like which patients are at risk, okay, is what is their vascular risk profile when we're talking about stroke. So if you have somebody who's 35 years old and has no hypertension, no diabetes, and they've had vertigo, we're going to find out it's migraine, maybe it's vestibular neuritis, maybe it's BPPV, maybe it's not going to be a stroke almost all the time, okay? But if you have a 75-year-old with all the risk factors, including AFib, and they're not anticoagulated, different story. And these are, two, they don't project super well for me or for you guys, but the Sudbury Vertigo Risk Score, okay, there's a low risk here, it's less than 5. You can Google these things if you're that keen. High risk is more than 8. These are validated to some degree, right? But some of the things that drive up your risk, being a man, being older, over 65, diabetes, hypertension, and then the things that actually drive the risk, right, is actually comes back to the exam and the history. If you have motor or sensory deficits or symptoms, that shoots your, like obviously now we're worried about a stroke, right? Someone says they've got vertigo and they're hemiparetic, we're much more concerned. And then if they have cerebellar findings, which in this score is defined as diplopia, dysarthria, dysphagia, dysmetria, and ataxia. So, a couple of these things are objective and some of them are subjective, mainly the diplopia and dysphagia we don't often test with the patient in front of us. And then you lose a whole bunch of points if you diagnose the patient with BPPV, which is based on the physical exam, and obviously we're now way less worried about them having a stroke and BPPV, right? The Triage Plus score is another similar, score, and has similar, some similar features. The absence of triggers, so triggers are like head movement is the main one we're going to talk about, but head movement or change in body position, quite reassuring for like a stroke, which is mainly what these scores are trying to predict. The presence of atrial fibrillation, absence of triggers, being a man again, high blood pressure. If you have features on exam or by history suggesting bulbar dysfunction, if the patient has focal weakness or speech impairment, if they have vertigo itself is actually usually benign. Like I said, dizziness, a little bit more likely to be something there, right? And then if they have no history of something similar, you get more points as well. Mentioned migraine. Migraine's a really common cause of spells of vertigo. So someone's had these things before. You can have recurrent BPVV. Don't often have recurrent vestibular neuritis. Vestibular migraine, it's like any other migraine. It often recurs. So the first question you want to ask a patient is about onset. Is this a new problem? Is it acute today or in the last couple, or is it chronic? Okay, that's at the big dividing line in vertigo. And is their first ever episode, or have they had other, attacks in the last little while? And, is there any preceding exposures? Trauma, certain medications can cause vestibular side effects or vestibular dysfunction, or like an infectious symptoms, like they have a recent URTI. The next is the timing of this problem. Is this an episodic? And this is the most important thing to drill down on, okay? And this is hard. Patients like, look, I'm just dizzy, man, okay? But like, this is what you need to find out is how long are you dizzy for, okay? When you have vertigo, so they're like, yes, the room spins around me. Is it spinning for hours? Is it spinning for minutes? Is it spinning for seconds? BPPV is a short issue. It is less than a minute, okay? It's usually less than 20 seconds. It's like 10, 15, 20, 30 seconds. But it feels horrible. And after the spinning's over, the patient's dizzy and they want to barf. And peripheral vertigo is often much more nauseous to the person than central vertigo. That's something that a lot of people don't know, is like the dizziness or the vertigo type symptoms you get with a stroke, usually not that bad. It's actually the patient that has an acute peripheral vertigo. They're very, very unwell from the vertigo. And so you have to drill down with the patient. How long is the spinning actually there for? If they say it's been spinning continuously for hours, it's not BPVV. But if it's, it might be 30 seconds and it might have happened 50 times because every time they turn their head, it starts again. But we need to figure out exactly how long the individual attacks are. And that is like the most critical thing. So is this an episodic disorder or is it a persistent problem? If it's an acute, persistent dizziness, that is a completely different thing than an acute episodic dizziness. Okay. And then the next thing is the triggers. The big triggers we want to talk about is, and we really want to define, is this a trigger, okay, meaning you do this and the symptom happens, or is it just an exacerbating factor? Because all vertigo is worsened by moving, okay? It's like, it's vestibular problem, essentially all forms of vertigo, like head motion is not their friend. But it's different that when I move my head, I feel more unwell with my migraine, or no, I'm fine when I'm still, but when I turn my head, boom, vertigo. So we want to find it as a trigger and the temporal relationship between that and the symptom. And then, some main triggers we want to think about is head movement and then body position change. Because the two main causes of acute episodic vertigo is orthostatic hypotension and BPVV. And that's, change in body position is for the orthostasis, of course, and BPVV is head movement, okay? And the classic story that you get is somebody that is rolling over in bed, okay? Or they're turning, they're shoulder checking in their car and they get dizzy. But often you get this rolling over in bed, or they wake up in the morning and they feel terrible. They just feel like dizzy and gross, and it's because they've been having vertigo all night in their sleep, okay? There are other forms that can be, so there's like rare things here that's worth asking about. Sound-induced vertigo, you'll feel very smart when you diagnose superior canal dehiscence or a perilimb fistula and send the patient to the ENT. Okay, so that's Tullio's phenomenon. It's got an eponym. Visually induced vertigo. We're not going to touch that much on it, but you see visual induced vertigo is a cardinal symptom of PPVD, or visual induced dizziness, not so much vertigo. And post head injuries in that you see that sort of visual induced dizziness. And Valsalva induced similar inner ear problems, structural inner ear things like superior canal dehiscence, perilimb fistula, get Valsalva, and then boom. Also with like a posterior fossa mass lesion or an AVM or something, you get venous backfilling. And so these are worth asking patients about. And then there can be things like dehydration for orthostasis, certain medication exposures if it's a side effect causing their dizziness, exertion and whatever. So, but the big ones I wanted to emphasize, these are the three things. The character of the dizziness we touched on, but it's less important. Patients are not accurate at describing their dizziness. This has been studied. They have a very difficult time telling you what's happening when they're dizzy. But if you can just, ask them about it, listen to what they say. If you get a nice story of the room spinning, you're like, I'm more in the vertigo camp than unsteady, dizzy, pre-syncope. But even that is not that accurate. And when multiple people take histories, the med student goes in, the resident, then you go in, then the specialist to get 4 different stories. But the timing, the triggers, and is it acute or chronic? This is fairly reliable between histories and is much more diagnostically useful. So these are the things you want to think about. Okay. So then we've come through, we look at our 3 main questions here. The onset, acute, chronic, okay. We got timing, is it episodic or is it persistent? And then we have triggered or spontaneous. That's the approach. And in each of these buckets, there's a differential diagnosis. Okay. So we're going to talk about our 4 forms of acute vertigo on the left. Okay. Triggered episodic vertigo. This is the big one. Okay. Triggered episodic vertigo, characterized by recurrent brief episodes, okay, of vertigo or dizziness that are precipitated by specific factors, the main ones being head movement and body position changes. Patients often feel really sick from this. Okay, it's very uncomfortable. If you do a Dix-Hallpike in your office, have a garbage can ready. The patient may vomit. Okay, but nausea, vomiting. People can be unsteady. Okay, that's something that if they're unsteady, it can't be peripheral. Like when you're dizzy, it's and people that have had untreated BPPV, it's one of my pet peeves. It's a very satisfying thing to do a Dix-Hallpike in the neurology clinic and make a diagnosis of BPPV. It's very unsatisfying to think about a patient that's been living with this for 4 months, and all that needed to be done was a few head maneuvers, and their suffering could have been avoided. Right? It's very unsatisfying. So, but a patient that's been sick with BPPV that long, at that point they're sensitized. They need Erica's help. Every time they move their head, they're freaking out. They can barely walk because they're so afraid they're going to get dizzy. And so you do see things beyond just just vertigo when someone's been sort of dealing with this for a bit. And BPPV is the main diagnosis here. Orthostatic hypotension is another one. We can sort this out with an exam bench and a blood pressure cuff. And then there's some uncommon things like I mentioned, canal dehiscence. Rarely you can get like a central positional vertigo with a stroke. It's really uncommon. And the main things in your office you want to do for these patients is postural vital signs and a Dix-Hallpike maneuver. Okay. So just because it's called benign doesn't mean it's not a big deal for the person. Okay, it's really disabling and really uncomfortable, and it can be diagnosed at the bedside. What is the cause? Okay, calcium debris falling from the utricular sac, getting stuck in a semicircular canal, kind of throws off there's a gelatinous kind of fluid in the semicircular canals. You got these crystals that are sitting there. It's pulling on the fluid. It's triggering neuronal firing, and it's as if like the head is being turned all the time. So you get the sense of spinning because your canals are off weight with this calcium debris. These autoconia, these pieces of calcium, they detach often spontaneously. Okay, it's more common in patients as they get older, heading towards retirement age. Okay, but it can happen in younger people. And while it's often spontaneous, sometimes there's actually a history of trauma. So sometimes what we see here is you see someone that has an MVC, they got a concussion, they're having some headaches, and they're dizzy. And one of the mistakes is you're smart, you went to Vertigo Talk, like, yeah, this vestibular migraine, yeah. No, you still got to do a Dix-Hallpike because sometimes this patient has, a minor head injury and they got some headaches and they got vertigo. And you might be right. In a lot of patients, it's vestibular symptoms from their head injury. But in some of them, it's actually they have BPPV. They knocked a piece of calcium loose in the car accident. And by not doing a Dix-Hallpike, some Epley maneuvers, if you can't fix it in your office, sending him to a therapist, like that patient's not really going to get better. And that recurrent vertigo attacks that they're going to suffer from that crap in their ear, they're going to like be even more sensitized and neck stiff and pain, and it's just going to make everything worse, right? And so it's super important to think about this and look for it. And I mean, I would argue in anybody with vertigo, like unless you have an alternative diagnosis, you should do a Dix-Hallpike. Okay, that's my own practice with these patients, and I see it less often than you because a lot of the time the BPV is found in the primary care setting, but I still do it because it happens often enough. Patient comes in and they may have two problems. They may have suffered, they may be seeing me in the stroke clinic. They mentioned they also have dizziness. It happens in my epilepsy clinic. They have epilepsy. They go, oh yeah, you know, man, in the last few weeks I've been having these like spells of dizziness. I've been waking up in the morning, I don't feel good. I do a Dix-Hallpike. I'm like, man, you got BPV too. Like it's a pretty common problem. Yeah, so yeah, I put on the slide here. So like one of the big ones is turning the neck or rolling over in bed. That's a really kind of classic story. And patient that can really tell you what's going on, they'll tell you that it's like a brief attack, stereotyped, and really good historian will say, yeah, it's when I turn my head to the left. They'll even tell you which side to check, okay? And then features on history that have a really high positive predictive value, duration less than 1 minute, and rolling over in bed being a trigger. This is a graphical picture of the utricle and showing you the autoconia, and it shows you as it falls over, see these little kind of white dots are falling into the, maybe I can do that again. Yeah, so here they're where they should be, okay, and then this, now they're going to be knocked loose, and you're going to see those little bits kind of fell into the semicircular canal, okay. So the gold standard test, okay, is the Dix-Hallpike. It's diagnostic, okay. It's just if they get vertigo, it's not diagnostic, so like you got to get more than that, okay. The typical response you're looking for, and I have a video too, is that we'll do the maneuver. We'll show you at the end with a live demonstration, okay? But usually get vertigo triggered by head movement to one side, okay? There's a latency of a few seconds, so you can't just put their head down and then, I don't see anything, and sit them back up, wait, okay? But it's usually 5-10 seconds or something you start to see, and you'll see the eyes go up, okay, and they rotate to the side with the ear down towards the floor. So there's this kind of rotation of upwards and rotatory. And it lasts the duration that they're dizzy. As the vertigo stops, the patient stops wanting to vomit and the eyes stop moving. So what you do is you look very carefully at the eyes. You want them to keep the eyes open. You watch for the eyes spinning up towards the floor. Now, if you see other things, you look and you're like, man, those eyes are going down. They're going like towards their feet. That's not, there's something else is going on. Could be anterior canal variants of BPV, you get different patterns, but it's more complicated. At that point, maybe call a friend, okay? Like, but if you see typical BPVV, we'll show you what the stegmas looks like. You see that, you're done. You've diagnosed them. You don't need to do, unless you have suspicion for a second problem, you figured out their vertigo. Congratulations, now we just treat them. So super satisfying, okay? And this is for posterior canal BPV, which is the vast majority of cases. It's far and away the most likely thing you're going to see. So first thing you want to do with this is you want to tell the patient that they're going to feel sick from this maneuver. So like, I'm not joking, get the garbage can and have it close by, because it's not uncommon that people get unwell, but you tell them, we're going to make you better. Okay, we've got to diagnose you and then we're going to treat you. It's helpful to know what the symptomatic side is first, because then you can screen the non-symptomatic side and get the patient used to the maneuver so they know what to expect. So they say, yeah, you know what, when I turn my head to the left, that's when I'm getting the symptom. Do it to the right first. Then you can practice on the patient. Remind yourself how to do it. The patient's going to know what to do. They're going to be a better test subject for you because they're going to be used to the maneuver. And nothing probably is going to happen, okay? You could have, autoconia debris in both ears, and it's going to be bilateral too, like that's unfortunate. But most of the time, there's going to be an asymptomatic side, symptomatic side. So check the asymptomatic side first, okay? And then you want to get them on your exam bench, exactly like the picture shows. You want to have them sitting, the top picture, the bum is too far towards the head of the bed, okay? But you want, like maybe like a foot down, and so that when they lay down, their head's going to be dangling off the bed, because you actually want the neck extended a little bit. You don't want it flat. Here we're going to do it with a pillow, but you want a bit of hyperextension in the neck, and then you're going to have the patient, so you're going to sit them up, you're going to turn their head 45 degrees, then you're going to lay them down with the head in that position, and with hyperextended, and you're going to just watch the eyes. You're going to tell them what's going to happen. You're going to hold their head. You're going to be right there, and you're going to say, whatever you do, keep your eyes open, okay? As soon as someone gets dizzy, they close their eyes. So you need them to, and you're looking for the nystagmus, so you need them to keep their eyes open. So give them a bit of coaching, and then you want to lay them down fairly quickly, but you don't have to, it's not like a crazy thing here, but it's like a fairly abrupt movement. Lay them down, get them in position. Erica is going to show you the optimal technique on how to do this, okay? And then do the asymptomatic side, then do the symptomatic side. And then here I have a video. So this is the this is the nystagmus pattern. So hopefully folks can see. There's the other screens there as well. So mostly what we're seeing is upward eye movement, but there's a slight rotation towards the patient's left, towards your right. It's hard to see here, okay? When the patient is like inches from your face, it's a lot easier, but you're going to see mostly an upward movement with a slight rotation, and it should be towards the ear that's pointing down. And maybe show it one more time. And so the eyes are going to do this, okay? And they're going up, and they're turning like that. And so there's this kind of movement there. You can kind of get an idea, hopefully, from that video. Both eyes do it. Yeah, great question. Both eyes. It's an upward and rotation towards the one side of the head is going to be towards that, and it's going to rotate towards the ear that you've turned to. So the kind of eyes are going over towards the side of the head and up. This is another maneuver you can do for extra credit. Okay, so you're like, I think this patient has BPPV, and you're like, I've taken a good history. I looked at the onset; it's acute. I got the timing, it's episodic, it's less than a minute, and the triggers, rolls over in bed, I'm sure it's BPV. And then you did the Dix-Hallpike, and you're like, man, nothing happened. It's not that. But then there's other canals, okay? There's the posterior semicircular canal, there's the anterior semicircular canal, and there's a horizontal canal. The anterior canal, the way it's shaped, often these patients will fix themselves. The horizontal canal, they also often will fix themselves just rolling around in general day-to-day life and turning their head, but sometimes they don't. I've actually only seen this once. Erica's seen it, I'm sure, much more than me, but I've only ever had one good case of horizontal canal BPV, and it was my 4th day at Surrey-North Hospital as an attending, okay? And I couldn't figure out which side it was, so I made the patient do the maneuvers to both sides to fix it, and then I came the next day and he was better. So, yeah. He did it all night, him and his wife. They did these maneuvers all night, and then I came the next day, and he was like, I feel great. I don't have it anymore. It was super cool. But yeah, anyways, this is a very simple maneuver, okay? You lay the patient on the bed. Once you've done the Dix-Hallpike, and you're like, you're right there, okay? Now, instead of having the head extended, you actually flex the neck a little bit forward, and you turn the head to one side, okay? And you just wait, and then nothing happens. You turn to the other side. It gets complicated. You get horizontal vertigo here. It can be beating towards the floor, away from the floor. You can figure out using a textbook which side's affected, but at that point, like, you've diagnosed horizontal canal BPV, just refer them to someone that does rehab to fix them, okay? There's maneuvers here, but like, I couldn't tell in Surrey Hospital which side was actually the bad ear, so I just said to the patient, do these maneuvers both. It was not the most comfortable for him, but he was fine. He got better. Yeah. So, and you can like simplify this a lot, right? Like most of this, sound-induced vertigo is really uncommon. Triggered episodic acute vertigo, and you're like, okay, you said orthostatic hypotension and BPPV, I did the maneuvers, and you can usually figure out what it is, okay? If you do the Dix-Hallpike and it's positive, patient gets vertigo and they get nystagmus, but it's not the nystagmus I just showed you. It's doing weird stuff. It's going down. It's going just to the side. You're like, whoa, that's not what the video looked like. Could be central problem. Now we got to, so then you want to get an MRI and talk to a specialist, okay? If you have a patient that you're like, vertigo, it's not the orthostasis, it's not the Dix-Hallpike, but they keep telling me that when they're like listening to Spotify on loud, they get dizzy, then CT temporal bones and send them to an ENT. All right. Spontaneous episodic vertigo. Okay, so we don't have an obvious trigger. Could be worse with head movement, but it's not just triggered by head movement. Could be worse with body changes, but it's not just triggered by it. And often when the patient comes, they're asymptomatic because they're avoiding their triggers. In this situation, the most common one is vestibular migraine. And vestibular migraine is the big mimicker here because you can get seconds of vertigo. Usually you have minutes of vertigo. Sometimes you have hours. So it can look like almost anything. And sometimes you have headache and sometimes you don't. Meniere's disease and vestibular migraine, Eric and I were talking about this before the talk. They sort of exist to some degree on a continuum. Okay, there's some debate about, are these actually kind of different presentations of a similar problem, or how are these two conditions linked? There's also a fairly high comorbidity of Meniere's in people with migraine and vice versa. Panic attacks, there's pre-syncope without a trigger. There's like other things in here, but And because it can be hard with the patient to tell if they have triggers or not, they're not sure, you're going to do the maneuvers. You check their orthostatic vitals and check their Dix-Hallpike, because, I mean, like, yeah, it's objective, right? But yeah, this is like the under-recognized, you know, big mimicker here, vestibular migraine. I think a lot of dizziness that you see in your offices is this, okay? And I think the teaching that folks get on vestibular migraine, including in a neurology residency, is fairly minimal considering how common it is. But you already have the skills to manage this. Recognizing it's a bit more tricky, but I just told you it's really common, okay? So if you've kind of reasonably excluded bad stuff with their history, their risk factors, their physical exam, they got no other features, you know, like a lot of the times you're going to find this. The same skills used to treat regular migraines are applicable in vestibular migraine. We don't have to panic. It's the same thing. So acute treatment, triptans work really well here. Okay, they work for the dizziness and the headaches. Give them some metoclopramide or some ondansetron or some good old gravel. Suppress the vertigo. Prevention. So you can use any of the migraine preventative medications for the most part. They work. They all work fine. But there's a couple that I've kind of, you know, I particularly like. Venlafaxine works very well for these patients for vestibular migraine. Start it slow. Migraineurs are often sensitive to side effects. They're just sensitized folk, okay? But start it slow, 37.5, work it up gradually. Target dose is 150, but you can get good effect with 75 or 112.5. Flunarizine is a very good medication. Counsel the patient on weight gain, rarely Parkinsonism from flunarizine, but that's an excellent medication for vestibular migraine specifically. And then the newer drugs in migraine that we're using a lot in patients with headache, there is actually reasonable evidence that's come on later than the pain relief literature on the CGRP medications. Fremanizumab, galcanezumab, both pharmacare covered medications for patients that have tried 2 other oral preventives. And they both have, you know, pretty reasonable evidence in improving vertigo and headache burden. The other arenumab, the other CGRP monoclonal, it's not a pharmacare medication. It also has a study showing that it's beneficial. So basically any of these CGRP drugs, it seems anyways that they are helpful for vestibular migraine. So it's similar to other migraines. Give them an acute treatment if they're having frequent attacks. And vestibular migraine is quite disabling, so give them a preventive medication. I like venlafaxine. Flunarizine is good. Tricyclic antidepressants also excellent here, nortriptyline, amitriptyline. You can give them the nutraceuticals, and magnesium, riboflavin, CoQ10. That's all good. And then if those basic maneuvers, you know, basic preventative medications aren't working, the injectable treatments, they work well. This is the diagnostic criteria of vestibular migraine. So this is from ICHD, and there's, you know, not everybody fits in this box, but most do. The first part, at least 5 episodes, okay? So if the first time you see this, you can't be sure, but a lot of the time that's what it's going to be. But you have 5 attacks, you can really diagnose it. It's the same as migraine. You need 5 migraines in order to actually diagnose migraine, even if you photophobic, phonophobic, nauseous, pulsating headache, like everyone knows what it is. But moderate to severe intensity, lasting between 5 minutes and 72 hours, okay? They should have a current or previous history of migraine with or without aura, okay? And then at least half the time, they should have some features of migraine, meaning headache, photophobia, phonophobia, visual aura, at least one of those. And it's not better accounted for, like every diagnostic criteria. It's not better accounted for by something else, okay? It's like the cover your butt thing they put in. And then you can also diagnose probable vestibular migraine, which they've, you know, really kind of knocked this out. We have the 5 attacks, 5 minutes to 72 hours, but you need only a current or previous history of migraines, or half the attacks have features of migraine. So point is, if you have somebody that has recurrent attacks of vertigo lasting hours, and there's a vague history here of migraine, you can diagnose them based on criteria with probable vestibular migraine. Migraine is common, it's 10 to 15% of the population. A lot of patients we're seeing with spells of dizziness, don't fear, it's just migraine. Okay. Spontaneous persistent vertigo. This is the one that you're worried about in your office, the acute vestibular syndrome. This is different. This is not spells of vertigo. This is vertigo that came on suddenly and hasn't stopped. These are the people that you're a bit more worried they've had a stroke, okay? Or they've had a demyelinating event, or they have a tumor, or they have whatever you're worried about when you order CT scans. This is the population, not the ones we were talking about before, okay? And the main differential diagnosis between these two things is vestibular neuritis and a posterior circulation stroke. Okay? And there's a sudden onset of the symptoms, gradual improvement usually over days or weeks. Patients are very symptomatic at the time of their initial clinical evaluation. This is where we rely so much on yourselves in your offices, the emergency room, to actually do the exam, because you send them to us, our wait list is terrible, and by the time they see us, they're better, okay, regardless of what it was, and then we're trying to figure out what it was, you know, months later when their exam's normal, because the time to figure it out is when they're symptomatic. And the bedside physical exam here is, you know, just as good, if not actually better, based on literature, than neuroimaging. And, you know, in these patients where you can get tripped up is that their symptoms are at rest, but they're worsened by head movement. It's different from BPPV. I told you that when someone says untreated BPPV for a while, they feel kind of crummy all the time, but they have head movement triggered vertigo. These people just have vertigo constantly, but it's worse when they're up and trying to move. This is where I wanted to talk about the physical exam. We've covered some of these things already, okay? Vital signs, including orthostatic vitals. Listen to their heart, otoscopy. These are sort of things you guys commonly do. You know, I'm a neurologist. I think everybody should have a reasonable neurological exam, but you know, a lot of those initial triaging bits, we're talking about bulbar signs and symptoms, hemiparesis, sensory loss. So asking some questions about that and getting comfortable with some maneuvers in the office to assess for weakness. Got a pronator drift, test a few muscles, watch them walk, you know, check their finger to nose, listen to them speak, okay? And then, you know, the main things that I want to sort of add to the exams you're already doing is the HINTS exam, which we're going to demo at the end here. And I got some videos, the Dix-Hallpike, and then the rest of it is stuff that you're pretty familiar with. Neurological exam, some cerebellar function, watching them walk, and then, you know, basic things, vitals and listening to their heart, looking in their ears. The head impulse test, okay? I got a video showing you a positive one upcoming here. Normally, right, when you move your head, your eyes are supposed to go opposite to the head movement. That way, when you're running, okay, and your head's bobbing along and you're, you know, doing your miles, the world's not bobbing around you. You can actually see, okay? Or you're, you know, you're on a, you turn your head to talk to someone and the image doesn't go blurry, right? Your eyes are supposed to move in lockstep with your head. It's why after a head injury or something, people tell you they feel dizzy and vision, like a lot of things bother them is because the head movements, their eyes are having a difficult time keeping up, and that's very disturbing to their function, okay? But in a healthy person, the vestibular ocular reflex is what does this. You move the head to one side quickly, the eyes move perfectly opposite to that. In someone with an acute vestibular problem, okay, a peripheral vestibular insult, the main one being vestibular neuritis, you lose the VOR on that side. So when you rapidly twist the head to the affected side, the eyes will not go opposite the head. So you get the patient to look at your nose, you move their head quickly to one side. We're going to demo this and show you the video. And the eyes, they go with the head, and then they have to generate a saccade back to look at you in the nose. You're watching for the saccade. You're not looking at the head and the eye. You're just looking to see if the eyes move. Because normally the VOR is so quick that you can't see the eyes move. They just look like they're straight ahead all the time. If you can't tell, the pro tip here is to get your MOA to film the patient's eyes with your smartphone. There's a slow-mo function on your smartphone. You can slow it right down and you can see what the eyes did, okay? And this is, you know, like, this is a pretty helpful maneuver, especially acutely. Chronically with a patient that's had a vestibular insult, the head impulse may continue to be abnormal afterwards, like just like a Bell's palsy where the facial nerve doesn't recover fully and the patient has a bit of facial weakness or some synkinesis. The head impulse test doesn't always recover completely, so you can find that chronically. So I look for that when I see them 3 months later. But the time to look was actually initially where they usually have a really big and obvious positive head impulse. Erica in her clinic has, you know, equipment to see a more subtle head impulse that's hard for those of us in a physician's office to pick up. But especially when the patient's symptomatic early on, like these things are usually, if it is vestibular neuritis, it should be present, and it's usually pretty obvious. And if you can't see it, the smartphone is usually good enough to find the finding. Okay, kind of talk through this here, and then we've got another video if you can play that for me. Okay. So watch this patient's eyes, and you'll see. So right now this is slowed down for you. Okay. And see the eyes there? Okay, so this one's positive to the left. Now, the video is going to go to the right, and the eyes, they moved, okay? But we'll watch, she does it one more time to the left. And then there's the saccade. Play the video one more time. The first maneuver is the most obvious. So this is what you start the maneuver with. You just move the head to get the patient kind of used to what's happening. See that? That's the saccade. So the eyes went, the head went to the left, the eyes went to the left, and then there was a corrective saccade to the patient's right. That time the head went to the right, the eyes moved nicely over to the left. And then it's positive again. The second time the movement's a little smaller, but it comes quite late. There you go. Okay. Okay. So the HINTS exam has a few components. It's an acronym, okay, and there's also HINTS Plus, which includes hearing loss. Okay. But the head impulse is the H in the eye. We have nystagmus, and then we have skew. The nystagmus is coming next. The skew is when you have vertical misalignment of the eyes. You can do that with a paddle like the ophthalmologist has, and I have in my bag at work, or you can just use your hand, okay? Very simple. Cover one eye, then the other one, and you're looking for vertical misalignment of the eyes. That's present, central, okay? If you find some horizontal misalignment, congratulations, you found latent strabismus. Or they have an old cranial nerve injury, whatever, but like it's not, related to it's the vertical skew is what we're looking for. And then, this nystagmus pattern. This is somewhere else where people get confused because they think, they learned in medical school that in peripheral lesions, you only get horizontal nystagmus, but then in the Dix-Hallpike, it's vertical, but no, okay, the Dix-Hallpike, we're talking about triggered vertigo. We're looking for that upbeating rotatory nystagmus. That whole horizontal versus vertical versus torsional thing is in the acute vestibular syndrome. And so in a peripheral patient, you're looking for predominantly horizontal beating nystagmus. There's usually a slight rotatory component, but for your intensive purposes and mine as a guy that has a hard time seeing anything, it's horizontal, okay? It's unidirectional. It just goes to one side away from the affected ear, okay? So the head impulse in that patient I showed you was positive in the left ear, and we would expect that this patient's going to have right beating nystagmus, okay? And it obeys this thing called Alexander's law. It gets worse when you look in the direction of the nystagmus. So if it's beating to the right and they look to the right, it gets even worse. And when you bring the eye away from the direction that's beating, it gets less intense. So it's unidirectional horizontal nystagmus, worse in the direction of gaze towards the fast phase of nystagmus. That's the peripheral pattern. Any other pattern of nystagmus you're seeing, we got to think about central causes. And the HINTS exam works primarily as a sort of like it's a rule-in tool for a peripheral problem. So if you're not sure, then you got to think about central stuff. But if everything lines up as peripheral, it's peripheral. But if there's pieces that are missing here, then it could be central, and you're sort of in the imaging camp. So you got a lateralized head impulse, peripheral pattern nystagmus, no skew. That's a HINTS patient. That's a HINTS negative patient, and HINTS positive patient, and they're peripheral. If the head impulse is non-lateralizing, they have no nystagmus, or the nystagmus is vertical, they have a skew or they don't, now we're in a central pattern. In central nystagmus, it can be any direction, okay? But it's not the peripheral one. It's not unidirectional, it's not horizontal only, but you're getting vertical nystagmus, torsional nystagmus, nystagmus that goes to the right when they look to the right, goes to the left when they look to the left. That's a very, very likely to be central problem, okay? So the important thing to remember here is what are the peripheral findings on exam, and then remember those. And if you're not seeing those, then we're thinking about, could this be a central lesion? Okay. Nystagmus is the best time to look is when the patient is symptomatic. So if they had their vertigo over the weekend and now they're starting to feel better and you're not finding much in your office, don't be alarmed. By the time the patient's less symptomatic, it's harder and harder to see the findings. And so what is the reassuring HINTS exam? there is this mnemonic, okay, send him on home. And the plus is deafness. So if the patient has unilateral deafness, okay, that's not good. That means you got to look at imaging. With an anterior inferior cerebral artery occlusion, you get deafness. It was added after HINTS was published, and they made HINTS plus. But send them on home. Straight eyes, meaning they're not misaligned. Okay, there's no skew or no vertical misalignment. There's no deafness. Okay, the head impulse miss, meaning it's abnormal in one direction. Okay, the nystagmus is only in one way, and the home is they got otherwise healthy exam. Okay, otic, mastoid, and everything else. You can also think of this a different way of head impulse lateralizes to one side. Nystagmus is horizontal, beating away from that side. There's no skew. They're not deaf. They're reassured they have neuritis. Okay. The management of vestibular neuritis, if you're seeing them kind of like Bell's palsy really early on, there's a small benefit with steroids. Really, it's with follow-up testing results rather than clinical symptoms, but you can give them steroids, particularly if there's no contraindications, or they're like not a brittle diabetic or something, and you're not like worried about giving them some prednisone for a few days. If you're seeing them like, and they've had this for a week, steroids do nothing, so don't bother. Okay, and then give them something to take for the vertigo. It's going to take days, weeks for it to resolve. Medications, ondansetron, gravel, low-dose benzodiazepine can help them suppress the vertigo and function. And then Erica will talk to us a bit about therapy for these patients. And if you have a good HINTS exam and everything lines up, you don't need to image this patient, you've diagnosed them. In fact, in these patients, neuroimaging is not always reassuring, so you can have a small infarct in the brainstem and not see it on MRI. And in studies of people that know how to do a HINTS exam, the exam is actually more accurate than imaging. Okay, and then triggered persistent vertigo. So this is, as opposed to a spontaneous patient, that just came out of the blue. This is usually more obvious things. They're intoxicated. They just got a medication. Dizziness is one of the side effects. They had a major head injury, and they have like a labyrinthine concussion. But yeah, main one here is actually prescription. So do a med review. Okay, and then chronic vertigo. This is the one that I'm not going to actually talk that much. I know it's the thing that drives you guys nuts, but a lot of these patients have migraine. That's like the first thing I'll say. Okay. Triple PD is an interesting problem. It's a functional dizziness that often stems from an initial vestibular insult. I conceptualize it like, if you're a teenager and you have too much alcohol, and you have like way too much, vodka at a party, and then for years later, every time you smell vodka, you get really nauseous and you want to vomit. And with triple PD, if you have someone that has a vestibular insult, maybe they have vestibular migraine, maybe they have BPVV, maybe they've had a head injury, and now with routine day-to-day stimuli, passive motion, looking at like their computer screen, or they see a carpet like the one here that's kind of busy, or they're at the grocery store and there's a bunch of carts moving in front of them, they feel sick. They don't have spinning vertigo, but they feel dizzy. That sort of sense, that's just triple PD. Those patients can benefit greatly. There's a sort of a conditioning component, so can benefit from cognitive behavioral therapy. Vestibular rehabilitation would be very helpful for these patients, and venlafaxine. So in the patients with vestibular migraine, some of them also have some PPVD. The SNRI is very, very helpful. If you have a bilateral vestibulopathy, as opposed to the neuritis, you have an abnormal head impulse test on both sides. These patients are really interesting. We don't see them much in neurology, but they have very unsteady gaits because neither vestibular apparatus works. They don't have spinning vertigo anymore because both of them are dead, so there's no imbalance. But they just feel off walking, especially in the dark, because your body relies on vision, vestibular system, and sensation in your feet. You need at least 2 of those 3 things. So if you have a patient with bilateral vestibulopathy and like a peripheral neuropathy, they're screwed. They're going to have terrible balance. But you need 2 of those 3 things to walk pretty well. So bilateral vestibulopathy, very unsteady gait, particularly in the dark because you're knocking out vision. And these patients describe that when they're running or they're on a like a bouncy car or something, their vision goes super blurry because neither vestibular apparatus works, so their eyes are moving all over the place when their head's moving. Again, chronic vertigo, med review, post-traumatic, again, check a Dix-Hallpike because some of them have had missed BPPV and you can fix that. Exertion-related dizziness, mal de débarquement is an interesting syndrome. I've seen it a couple times in practice. Someone goes on a cruise ship, they get off the cruise ship and they still feel like they're on the boat. Some of them get better with SSRIs and time, anxiety. And there's, of course, like at the bottom, there's rare neurological disease. You have chronic vertigo as a manifestation of a late onset ataxia syndrome or something. Erica and I were just talking about an interesting patient we shared with that. So, migraine is very common in here. Okay. Just about at the end of what I wanted to talk about. I just want to kind of reiterate those things. So, in our history, we're gonna do the onset, the timing, the triggers. Those are the main things we want to find out about. And we're going to use that to work through that algorithm and looking at acute versus chronic vertigo, triggered, not triggered, episodic, or persistent. And then, we want to, nystagmus is helpful, but it's more than that with the physical exam. We want to do some typical maneuvers, Dix-Hallpike, Hintz exam, orthostatic vitals, check their cerebellar functions and those things. The repositioning maneuvers is the diagnosis and repositioning maneuvers in BPV is the management. The management is not beta histine, okay? One of the questions we got before the talk is, what is the utility of beta histine? There is none, okay? But the utility is in Meniere's disease, and I don't really treat Meniere's disease, but I never prescribe beta histine. It's not helpful. Instead of writing prescriptions for beta histine, do a physical exam, because that's, you can fix the patient with the epley. The beta histine did nothing for them. Where you need to have some concern about acute central pathology is in that acute vestibular syndrome, sudden onset, spontaneous, persistent vertigo. Go to the Hintz exam. If it's not lining up as a peripheral thing, then you want to get imaging, looking for central pathology. Okay, and I'm going to bring up Erica to talk a little bit about rehabilitation pearls, maybe, or we can do our demo. Okay, this is our facsimile of that. Typically, like I said, you want to have patients sitting, feet up, with Elliot's in a really good position here, but laying down, you want to kind of guesstimate that their head's going to dangle a little bit. And in your office, if you happen to have a pillow, it is helpful to get the shoulders up a little bit so you can get that neck dangling. I think Erica's going to demonstrate to the left, right?
Let's pretend that the left is worse. Is going to do it right first.
Okay, so we're going to pretend that Dr. Bagouche has a left-sided issue. So we're going to start with the right side and show you how we do that. So you're going to hold the head on the side of the head here. Okay, you're going to let the patient know it's coming. Okay, and you want to turn the head, okay, about 45 degrees before you lay the patient down. And most important instruction here for the patient is keep your eyes open. Okay.
Look at me, but don't fixate on my nose.
Yeah. The other thing is, like, fixation can suppress abnormal eye movements. Okay, so you don't really want the patient death staring you when they do this. So just ask them to kind of look at you, but not like staring at your pimples. Okay, so just get them to look, eyes open, but you want them fairly relaxed, and you let them know too, like, this may make you dizzy. Okay, give them a bit of warning, and you're like, this might make you dizzy, but keep your eyes open. That's all they got to do. Okay.
I'm going to count to 3, and then we're going to go down. 1, 2, 3.
Okay, and you see that position, so she's holding that 45 degrees, and then Dr. Bagouche's head here, he's got slight extension of the neck, and then Erica's looking carefully at the eyes, and like I mentioned, you're not going to see the nystagmus in BPPV right away usually. There's often a latency of several seconds, and then the patient usually says, "Whoa," because they're getting vertigo. Okay, and then from there you can. So we got nothing here. Now we're going to go to the other side, and we're going to do the exact same thing. Okay, so if you're not seeing anything, like, you want to kind of hang tight down there for like a good 20-30 seconds to make sure. Okay, the latency, like I said, is usually 5-10 seconds, but give it some time. Just chill out and watch. Okay.
A few things tying with all of that. So if you do this in patient who is acute or subacute, and you start seeing side nystagmus, that don't think that that is just BPPV if they have had just a very recent acute vestibular episode. So it might be that you're still seeing the spontaneous nystagmus, but it is sort of latent. So again, for this to be posterior canal BPPV, the eyes have to go up and around. If you're seeing side to side, then you're going to do the body roll and you're going to continue with your investigations.
And that's why I think it's really important to just, like in some of the literature, they talk about the Dix-Hallpike and like, you know, you don't apply it in a patient with acute vestibular syndrome. And I mean, my own approach with patients, like the history is really important for, you know, all of medicine. And, but dizziness is a very humbling history, okay? And, you know, the exam here can give you the diagnosis. Like this is not that common anymore, that the physical exam is like really the gold standard. And you don't have to like spend a lot of time trying to figure out, you know, their dizzy history. When you do a Dix-Hallpike, it's positive, and then posterior, like you're done. You've figured them out. Now you just fix them. So like, you know, really rely on the exam, and then more or less apply the same exam to each patient, because you know the history may kind of lead you astray. Is it triggered? Is it not triggered? Is it episodic? I can't tell. And then just do the exam, and then try and interpret the exam. And then after you've done that, and you're like, I still don't know what the heck is going on. Then that's where you know, think about investigations, and you know, maybe calling someone else for help. But a lot of the time, you are gonna find stuff on the exam, or the exam's gonna be totally normal, and you've taken a good history, and you're like, I think this patient probably has vestibular migraine, because a lot of them do.
So now we're going to do the right side, which is the side that he said it was worse. So same thing. And then we're going to go down, 1, 2, 3. That is a positive Dix-Hallpike. They're holding on for dear life.
Yeah, they usually start sitting up, right? They don't want to stay there, but you need to get them to just chill with you in that position, okay? Yeah. So that's the Dix-Hallpike. Maybe we'll go from that into the Epley maneuver. Yeah, because we've done a good chunk of the Epley maneuver already. So, so we've now figured out that Dr. Bagouche has left-sided posterior canal BBV. We looked at his eyes. They went up, and because it's left side, they go up and they turn towards the left, okay? So we figured that out. We know he's got left-sided posterior canal BBV, and now Erica's going to fix him, okay? So the Epley maneuver. Oh, yeah.
So then you're going to tell them, you're going to feel dizzy all over again. I'm so sorry, but now it's for a very good cause. Now I'm just going to get rid of the crystals. So then position 1 is the first one, is the Dix-Hallpike. You're going to start with the head 45 left, and then you're going to go into extension. You're going to stay there until dizziness goes away, plus the same amount. So roughly a minute. You do not want to rush into that Epley. So wait until the dizziness goes away. Say, I got you here, stay here. Then you're going to turn the head 45 to the opposite side, or to the right side. And then, without lifting the head, you're going to roll onto the right side, the unaffected side, with the nose pointing down. The not lifting the head is just because you don't want the crystals to convert and to go into the horizontal canal. You want to direct the otoconia into the utricle. So I'm just going to demonstrate that. But again, I will do it not waiting a minute in each position, but a good, if you want to do a good Epley, 20 seconds of dizziness, 40, 50, 60 seconds in each position.
Yeah, so don't rush that. And the other thing I'd say is, like, for most of our offices, we usually have, at least where I work, a lot of time the exam bench is up against the wall. This is a time where if you're seeing a patient with this and you're going to do this maneuver, you often want to try and move your exam bench away, because you'll see where Erica's located, but you kind of need to get around the patient, and the patient's going to end up needing to get up on the, in this instance, on the other side, on the back side of the bench. So if the bench is up against the wall here and there's no way for Dr. Bagouche to get off the bench, then you can't really do the maneuver. So you kind of want to rotate the exam table so it's perpendicular to the wall, or at least there's an angle on the back side of it so the patient can get off. You'll see in a sec what happens. Okay.
And to that, and again, it's helpful sometimes for you to start with them closer to the affected side, so closer to the left edge here. I'm not gonna get him to do that, otherwise this table is gonna tip. But that would help your patient to have room to roll into the position 3 later on.
So just 180 the patient for the other side.
So position 1 is Dix-Hallpike, and here we go.
So I think Erica's going to rush it a bit, but normally you want to give in each of these positions, you know, a good 45, 60 seconds, especially the first one. You want that dizziness to be long gone and then wait about that same amount of time it was there for. So this is position 2. So it's very similar, right? All we've done here is we've moved the head, you know, to the other side at 45 degrees. We've just moved 90 degrees. You just turn the head from this side to this side, okay? Like the windshield wipers on your car, that's it, okay? Okay, so then symptomatic to the left, we've rolled 90 degrees to the right. Now we're rolling again, another sort of 90 degrees down, so the eyes are looking at the floor, and you get the patient, this is where you want to have the bed, you know, away from the wall, and you want to hold the head so the crystals don't go backwards on you, and then help the patient sit up, and then the last part of the maneuver is just bringing their head into neutral, into the first position, or into straight forward position. That's the Epley maneuver, that's it, okay? You don't always fix patients with one, so sometimes you need to do multiple.
And I held on to him because sometimes if you have a very strong BPPV, once the crystals fall into the utricle, you can have a reflex of going backwards, and they really literally feel like they're falling, and so you hold on to them. I had one just this week, and I said to her, I'm gonna hold on to you. She goes, I'm okay, and then had the reaction. And she looks at me, how did you know? Yeah, I knew. So you hold on to them, you don't let them go for at least 30 seconds.
Yeah, I think that's good for those maneuvers.
Modifications for people with reduced neck range of motion. I might have been able to really turn to face the floor.
Do we want to go
Yeah,
there?
we can show. Yeah, we'll show you the Samant maneuver. Okay, there's and you know, we want to do a live demonstration. There are I think we have it on somewhere on the materials, but there are really nice videos available on Pathways, and like Dizziness Canada has some nice videos. On YouTube, there's like University of Michigan has nice videos of these maneuvers for patients. Sometimes I send them there. So there's lots of places you can see this stuff again.
Can you hold it for me, because I only speak with my hands on this
Yeah.
one. So, yeah, if you can hold. So again, if the affected side was the left side, the left posterior canal is this way. So what I will want is the patient to turn their head opposite to the affected side, and then they're going to lie on the affected side shoulder, and then onto the other shoulder, nose down. So I put the posterior canal in plane of stimulation by turning the nose away, and then onto the left shoulder, and then onto the right shoulder, nose down. I'll show holding his head from back, just so you can see, but that's what I'm doing, okay?
This maneuver is easier, I think, for patients to do at home because they can do it
Yeah.
on the side of
So
their
then they can
bed,
see.
I
think
especially if they have a partner or a
if they could see.
parent, child, like somebody at home to help them. You know, like, you know, if you show the patient in the office the maneuver once and give them a video to watch, like, you know, you and I don't have time to do these
Here we go.
maneuvers,
1, 2, 3.
you know,
nose
8
down.
times with the patient in the office. But if you show them once and try it and they're still dizzy, then you can, you know, they can do it at home after, and then you can bring them back in a week. And if they're still dizzy, then send them to a skilled therapist. So that's a Semont maneuver.
Good patient.
And then maybe some
I'm
hints.
just gonna do it again, just from front.
Okay,
So
Erica's going
I'm
to
just
demo
gonna
it
do
again from.
like I would at the office. So I'll demo the other side. So now if
His right side was affected.
right side affected,
We're going to
turn
go to
the
left
nose this way, come back first.
towards the affected side. It's almost like the pendulum on a clock. Okay, so
And then
or a metronome. Okay.
yes.
And then the patient can take a break and then try it again, right? And like I told you about that horizontal canal patient at the hospital, him and his wife did the maneuvers all night until it was better. So sometimes it takes some effort to get those crystals out. Okay, and then I think the last thing I wanted to show is show the hints exam. Just I showed you a slow-mo video, but try and show you guys like what exactly is involved. You know, how much do you move the head? How fast you move the head? Okay, so small movements to get the patient kind of, you know, small gentle movements just to kind of get them to feel the motion and kind of lull them into sleep. And then it's a small, quick movement, and you can hold the jaw or you can hold the temples. Okay, and then quick movement here, and then you're going to look carefully at the eyes for that saccade. We saw the slow-mo video, and if you have a resident or MOA or nurse or somebody. And you know you're not confident or you just want that backup, then the phone's really nice for that. Yeah, the skew is really simple. Okay, okay, you just look carefully. You get the patient to fixate in the distance. You don't want them looking at your nose and accommodating. So you ask them to look at a point in the room behind you. So I'd ask Dr. Bagush maybe look at that TV screen over there, and he finds a and then okay, and you just cover one eye and look the other one, and you're looking for vertical misalignment. That's it. Nystagmus, okay, very simple, but the finer points. When you put a finger right in front of someone's face and ask them to follow, it's very uncomfortable because they have to accommodate. So step back from the patient a little bit, okay, follow the finger, okay, have a look at the eyes, okay, pause out at the extremes, okay. If you go too far, you're going to induce a bit of end gaze nystagmus, couple beats, okay. But in the acute setting, when someone has fulminant vestibular neuritis, the nystagmus is not subtle. It's often there at rest, okay, to some degree. It's the patient will eventually overcome the nystagmus with fixation. So one of the things that Erica will do in her office is block fixation with Frenzel goggles to try and unmask the nystagmus. And most of us can't do that easily in your office. You can with a fundoscope, and it is possible to try and block fixation without fancy equipment. But in the primary care setting, like patient comes in, they call you, they tell you they're super dizzy and sick at home, and they had a cold over the weekend, and you bring them in and their eyes are bouncing around. They're going to be symptomatic usually. They're going to have the head impulse lateralizing to the affected side. They're going to have nystagmus beating away, horizontal, worse when you look towards the nystagmus, better when you look close, and no vertical, no rotatory nystagmus. And it's just horizontal movements and up, down, and that's all you have to do on that. Anything else you'd like to see in the physical exam before we close that section?
I have a question.
Yes.
So when he went down on the athlete, so you took him down and he was dizzy, so then you waited, once the dizziness went away, was it another minute from there or 30 seconds?
Yeah,
Another 30 seconds.
Another 30
total,
seconds.
total a minute.
So then when you turn him 90 degrees, does he get dizzy again because he grabbed on?
Not so much on position 2, more so on position 3, but they do get,
So it comes again.
it does a little bit.
A little bit. You get at each movement, you sometimes get a little kind of shudder of dizziness, okay? But it's not like the first one. But at each position, you want to wait. Like the epilepsy, to do it properly, takes a while. So you want to wait about a minute in the first position, and honestly, 30 to 60 seconds at each position. Yeah, the longer kind of the better. I mean, I know you don't have a lot of time, but you want to give time at each point, show the patient. And like I said, if you show them how to do it and do it with them, and then give them some videos, they can probably do it at home. The epilepsy is a little tougher than the Semont maneuver but you know, it's not that hard. Like we just showed you now, and you know, it's pretty.
So once you do one round of the epi, you set them up, what percentage of people are usually better by doing the
I don't know. It depends on how many crystals there are and how good your epilepsy is.
So studies show that if you diagnose it properly and just your straightforward BPPV, 70-something% success rate with one appli, and it goes up to 95% plus if you do 2 applis. So technically, you would want to do 1 appli, get them to just wait 5 minutes, 10 minutes in the wait area, come back and do another one, and then send them home. And then you can check in with them a few days after. There is such a thing as feeling worse and feeling a little bit of, we call it BPPV hangover. So the first day or two, particularly if they've been having BPPV for a while, they will be worse in the first and second day, but from day 3, you want them to kind of test themselves and let you know if they are well.
Yeah, and you test it with the Dix-Hallpike, right? You can, so like after you do the maneuver, like sometimes I, do it once and, fix the patient. And sometimes I've done it a couple times and I'm like, I don't know. So then I instruct the patient to try it again at home. This is the diagnostic test. So if you're trying to figure out if they still have it, then do the maneuver. And so once you do an epley maneuver, if the patient says, they kind of recover from, and they're like, I feel a little different, you can do a Dix-Hallpike again, which is the first part of the epley maneuver. And if nothing happens and they're like, I'm better, then you fix the problem. Okay. Yeah.
Any alternative tests that you recommend for people that are like wheelchair bound or unable to get to the exam table or back or neck issues?
There is a group of Italian doctors calling now minimum stimulus strategy, and they do this actually on a chair. So they kind of have the patient a little bit forward on the chair and recline, and you can get that extension actually on the chair. So you can, I have tested, it does work.
Yeah. But there's no diagnostic test you can order to do this. Like it is, so somehow you have to, try and we get that, I get that on call quite often, right? The patient's heavy set or the patient's old. It's not a reasonable excuse. I think it's like, I haven't been exactly kind to some people that have said those things. Like, just because the patient's heavy or they're old doesn't mean they don't deserve care. So, figure it out. Get a nurse to help you, another doctor, their family. It's pretty uncommon that in my practice I can't examine a patient. Like, I literally cannot do anything. There's always a strategy, a way to provide that person care. I view it as a pretty lame excuse that their physical condition precludes you from testing them properly.
So sometimes, you see some eye movements, and I keep testing, I keep doing applis, and then sometimes this can actually be a vertical upbeat nystagmus, and it's not BPPV, and you're trying to cure something that is possibly central position. So after 2 sessions with a physiotherapist, you've done 4, 5, 6 applis. I've been doing applis at home and I'm still not well. Pause, go back to the drawing board, take a better case history, send it to someone who has goggles with the ability to record our movements without visual fixation. Can you go back?
Yeah.
Sorry. And then you see there, after the appli has resolved vertigo, like Dr. Arnold was saying, get them to test themselves and tell them and encourage them to go back to moving. No such a thing as after 3 days that, but I'm not still turning onto my left. We treated left side and then they continue to not turn onto the left. That's not what you want. This is a good recipe for chronic dizziness symptoms. So you want them to return to moving naturally. Like, put this episode in the past. After 3 days, I want you to do all the movements. And if you are still vertiginous, then we'll see what is happening. But get them to move. If they are still having some hesitation, you can give them branch thereof exercises, which is habituation. It's just to get their brains and their bodies habituated, used to moving again. So, talking about vestibular rehabilitation, in the acute spontaneous vertigo disorders, vestibular rehabilitation is not indicated. So if you are having patients with many years disease like presentations or vestibular migraine that is just purely episodic and your patient is asymptomatic in between episodes, do not send them for vestibular rehabilitation. Vestibular rehabilitation does not prevent the spells, right? So then you have to think about pharmaceutical options for prevention, which is what Dr. Arnold just said, nutraceuticals and all the migraine prevention or meningitis prevention. In later stages, they can have unilateral vestibular loss. So if you progress into a unilateral vestibular loss, they can have symptoms in between spells or persistent symptoms, and then vestibular rehabilitation is good. Again, for episodic, it's not recommended. What you have to try and encourage that patient to do is regular physical activity. There are studies showing that regular physical activity is a good migraine prevention. It's as good as supiromate if they do 3 times a week. So good resistance training and aerobic and cardio exercises, just get them to move. They don't need to spend the time and money with physiotherapists. They just go around the block and walk as if they are late for the bus. For chronic vestibular migraine or for BPPV, so then there can be vestibular rehabilitation strategies that are helpful. But what we do is, again, starting with general physical activity, as well as gentle exercises. In the beginning, we avoid head movements and eye movements because those can be migraine provoking. So if you have a patient with vestibular migraines and they say, I've tried a physio and it made me worse, they are onto something. It's just because sometimes the vestibular rehabilitation strategy is just too much and it can be provoking of spells. So be careful with vestibular migraine patients who are trying vestibular rehabilitation. For vestibular neuritis, for the acute, the ones that you've determined it's not a stroke, what you want is them to move their head as soon as possible. So as soon as they are out of the hospital and as soon as they are not vomiting anymore, you will have to say, to encourage compensation, you want to move your head. Your brain will have to start learning how to navigate your environment with that left loss, let's say, if it's left side. So I want you to try and move your head as naturally as you can. This often is enough for them to encourage a natural compensation, and it is the best prevention for chronic dizziness. Get them to move as soon as possible. Explain to them that it is going to be uncomfortable, and tell them uncomfortable does not mean that it is bad for you. At this point, after vestibular neuritis, it is going to be uncomfortable, but this is the best thing that you do to help your brain compensate for that loss. And for 3PD, for the chronic functional neurological disorder like Dr. Arnold was mentioning, there is this strong response and aversion and fear and avoidance of movement. Just like the teenager would not touch vodka anymore, this patient does not want to move. They avoid and they are afraid. So what we want to do is just explain to them what is happening and catch and show them all the maladaptive behaviors that they are presenting with. Often it is extreme muscle tension, so they hold their neck quite tight, and they're going to say to you, I think my neck has to do with this. The neck is secondary, just because they are avoiding. And then there is a visual dependency. They walk looking down, and they are avoiding everything that they used to do. And they will tell you, I used to do X, Y, and Z, but now I don't do it anymore because I'm afraid I'm going to fall. I'm afraid that this is going to provoke a dizziness again. So try and encourage them to return to natural activity.
When am I absolutely sure that my patient with vertigo is okay to drive, particularly when that is what they do for a living, like a transit operator?
Yeah, I mean, consult the Road Safety BC guidelines. Okay, they're pretty clear. There's a section on vertigo. It has to do if their attacks are triggered or not triggered, if they have warning that they can pull over with the car. It's fairly clearly articulated in terms of what's expected. I think it's reasonable, like if the patient is having, like sudden attacks of vertigo without, a lot of warning here. It depends on like the etiology, but they probably shouldn't be operating like a heavy-duty truck.
Next question. Do the CGRP antagonists work for vestibular migraines?
Absolutely. Yeah, we mentioned that in the didactic. There's good evidence for particularly the injectable monoclonal antibodies. I haven't seen a paper, I just probably haven't looked hard enough, but I haven't seen a paper on the Atogepant, the preventive medication. But mechanistically, it would make complete sense. We think that CGRP is very important, in mitigating and mediating both the headache, but also the vertigo that's like way underrecognized in migraine. So I personally, I think vestibular migraine patients are really good candidates for CGRP treatment, and whether that's abortive treatment with the rimegepant, ubrogepant, those medications, or preventative treatment. Just like the patients with a lot of pain from migraine benefit greatly from anti-CGRP therapy, definitely think about those drugs in the dizzy migraine patients for sure.
Is Valium an approved treatment for peripheral vertigo?
You can use low-dose Valium as a vestibular suppressant, yes. I don't use a ton of benzodiazepines in these patients. I prescribe my fair share of short-acting benzodiazepines for epilepsy, but in the emergency room setting, I have used diazepam and lorazepam at low doses with good effect. Like I said, Gravol, ondansetron, Maxaran, prochlorperazine, all very helpful vestibular suppressants. Erica, do you want to add something?
I just want to add that if this is good for the acute, but long term, you don't want them to continue to take that, otherwise it will hinder compensation.
Yeah, and these are medications that are mostly like really in the emergency room or in your office for like the first few days or like the first week or two. Erica had a really nice slide here on neuritis, okay? And point 3 was ensure vestibular suppressants are not being used. The main patients with like the suppressants, you can use, like I wouldn't recommend using benzodiazepines in a migrainer as an acute suppressant, but a triptan and an anti-nausea medication like Maxaran, I definitely would recommend. An anti-nausea medication in the acute setting with a neuritis, definitely recommended. Benzos are just like not my favorite prescription, period. But yes, you can use them. All of these medications, though, you don't want the patient taking, the useless beta-histine or whatever these prescriptions we're using, indefinitely. They're short-term thing, just like benzos for a panic attack. But then there has to be a long-term plan of, and so when someone with vestibular neuritis who's lost function in one of their ears, we need to treat them when they're vomiting in the emergency room, and for the first little while, get them off the meds and get them into some rehab to get them back functioning. We want them off the medications and back to like exercising eventually. First, we want them to walk and move without feeling dizzy, okay?
What are common medications that can trigger vertigo or give it as a side effect?
That's a long list of dizziness, like a lot of the central acting drugs. So things I use, anti-epileptics, okay, particularly with toxic doses, very common to cause dizziness and vertigo, dilantin toxicity, lamotrigine doses too high. So if you have a patient that's enduring chronic dizziness and you look through their medrec and they're seeing a neurologist or a psychiatrist, they've seen one in the past and they're on that group of medications generally, those are the ones to consider. The other class is antihypertensives. Maybe you're precipitating orthostatic hypotension, right? That was a key thing we talked about that we've kind of glossed over now. We're really focusing a lot of our talk on vestibular stuff, but Orthostatic hypotension is a common cause of episodic dizziness, is way under-recognized. You may not be able to elicit in your office. That doesn't mean they don't have it. If they're diabetic and have autonomic dysfunction on 3 antihypertensives because they've had a stroke and now they're endorsing dizziness, it's their autonomic dysfunction and all the blood pressure medications. So that's a super common class. And then there are like gentamicin toxicity, and there's certain medications that as a idiosyncratic sort of reaction or cumulative effect can cause vestibular damage and then lead to dizziness or vestibular failure.
How do I know if vertigo is really causing patient distress or if they are feigning for secondary gain?
Yeah, that's a challenging question to answer in this context. I mean, you know, I generally, I think, for the most part in this job, we're doctors, we're not detectives, okay? And we mostly have to take people at their word until they've proven that we can't, okay? And so, you know, I deal with a lot of subjective problems, right? Like a big part of my job is, you know, quote unquote, whatever that means, right? Most of what we deal with is the patient reported a symptom. That's a subjective thing. And a lot of us rush the physical exam, so we don't get a lot of objective data, myself included. And so we have to take people at their word, you know, and headache, vertigo, seizures, a lot of this is based on patient self-report. You know, I would tell you that disorders causing dizziness and vertigo are infinitely more common than malingering. Okay, so yeah.
That's all for our Slido questions. Does anyone want to just ask a question directly to Erica or Dex? I can bring the mic over to you.
Erica's contact information. I'm sure that Prab can get that if, no?
Or it's an easy one, erica@vestibular.ca.
It's very easy. She's got the right domain name. She's locked it down. Erica, we didn't introduce her position. She works at BC Children's Hospital in their vestibular dizziness program. And then on the adult side, she has a private practice at Boundary and Kingsway. I've shared patients with Erica over the last couple of years. She's incredibly helpful. If you can't figure out what's wrong with your patient, she will figure it out. You'll get a very long letter telling you all the things that you didn't know about your patient, and including what's wrong with them. And she'll tell you how to do the job as a doctor, what you do. So like very helpful. But you know, Erica's services, like these are like therapy in general, are unfortunately not covered under medical services plan. So you know, if your patient has benefits, you know, if it's a workplace issue, there may be some help in terms of, you know, cost. But you know, my patients that have privately gone to see Erica have told me that it was, you know, some of the best money they spent on their health in terms of understanding their problem and having like coming away from that appointment with a better understanding of the issue. So super helpful person to engage in your patient's care. We did have a question online, or like an email, about other people to, you know, engage around here, because I think somebody had asked that, and I thought that was a really appropriate question. And Erica and I were talking. There's a few people that I use locally, because like Erica is in Vancouver. So for patients that have difficulty traveling, at Elysian Health, there's a therapist there, Suki, who's interested and has skills in the vestibular realm. Close by this place, on Scott and Nordell, there's a LifeMark physio with, and I believe he's an occupational therapist originally, but Abid Herji works there. There's a very good physiotherapy rehab clinic on Highway 10 and 152 called Activate Neurological Rehab. There's an excellent clinic across the street from Surrey-North Hospital called Neuropeak. Erica had mentioned that she did a lot of the training for their staff on these disorders, and I've used them with my patients. Not only just vestibular neuritis or, you know, chronic vestibular migraine, but you know, post MVC with triple PD, sort of non-specific dizziness after a head injury, very helpful. And then there was Ladner physiotherapy as well. Devin is the name of the therapist at Ladner Physiotherapy. If you guys are located out in Tsawwassen area, would be our recommended folks to link up with.